IASSS is a student and junior doctor-led nonprofit organization. We aim to unite the world's existing pre-specialist surgical interest groups to facilitate the creation of new ones and to ensure that every aspiring surgeon around the world has the opportunity to connect with like-minded individuals, both locally and on an international level. Through the IASSS network, we hope that surgical societies across the globe can work together to set the agenda for the future of surgery. I was fortunate enough in 2019 to take part in a research preparation class hosted by Dr. Sosa. And today it is a pleasure to give our first talk as the IASSS and to have such an esteemed speaker to open this chapter of the IASSS. Dr. Sosa, I'm going to hand over to you now.
All right, awesome. Thank you so much for that warm introduction. And I am going to, let's go all the way up here to there. And let's see. Let's see. Hold on a moment. Everybody, just hold on 1 second. Don't worry, I'm not going anywhere. Right, there it is. And let's go to this. Are you guys seeing that?
Yes, Dr. Sosa, we can see.
All right, very good. No Zoom meeting would be a Zoom meeting without some appropriate flub ups. So first of all, thank you so much to the organizers of this session. It's an absolute privilege to be with you this morning. As you can see from my Zoom background, hopefully you can see, I am celebrating International History of Women's Month with a collage of all of the women in our Department of Surgery at UCSF, and you can see that there are a ton of them. And I wanted to recognize the fact that all of the organizers of this session are women, which to me is incredibly empowering and leads me to believe that the future of international surgery is even brighter than the present. Today, I'm going to be talking a little bit about my own life, but more about concepts that pertain to surgery and the science of surgery, and why I believe so strongly that innovation and discovery should be the underpinnings of what we do. So you'll have to bear with me. There'll be a little bit about thyroid cancer, a lot about mentorship and mentees, and we'll finish with a few suggestions about what to have in your toolkit to enable you to be as successful as you can be and to become the best version of yourself. So if everyone's wondering, where is Dr. Sosa? Like, where is Waldo? Dr. Sosa is in San Francisco, and this is Parnassus, which is the Moffitt Long Hospital. It's the sort of epicenter of the University of California, San Francisco. And I have circled my office because it's a big structure, and the office is fabulous. If any of you can come and visit me, I'm looking out over the Golden Gate Bridge and San Francisco Bay. But the University of California, San Francisco is a very big, matrixed and complicated health system. So this is Moffat Long, Parnassus up on Mount Sutro, but we have a number of other hospitals affiliated in our department, including this, Zuckerberg San Francisco General Hospital, really one of the most famous trauma hospitals in the United States. This is our Mission Bay Hospital, which is where we do children's surgery. It's where obstetrics and gynecology is, and where we focus our surgical oncology, our cancer surgery platform. And this is Mount Zion, where we do a lot of outpatient surgery at UCSF. So you can see healthcare in the United States and training at UCSF is very complicated. Okay, so I went to Princeton University for my undergraduate degree, and Albert Einstein, this is Albert Einstein, spent a lot of time at Princeton at the Institute for Advanced Studies. So I always try to put a Albert Einstein slide into my talk. So Albert Einstein said something very interesting, many things that were very interesting, and this one is one of those. Quote, if I had an hour to solve a problem and my life depended on it, I would use the first 55 minutes determining the proper questions to ask. In other words, we focus so much on our analysis and on how we write up a manuscript and how we present a manuscript. But I would argue the scientific process really starts, and the heart of the process is asking questions that are either novel and or important. Well, why are we focusing on today's surgical science and academic surgery? Because it is declining, certainly in the United States, and I think it is in jeopardy around the world. Fewer surgeons are pursuing careers in academic surgery. Why? Well, I think almost certainly it is because of lack of funding, and because policymakers, payers, maybe even patients no longer put as much emphasis on surgical science. And by that, I mean funding to support these kinds of platforms. And in the United States, we have seen an erosion in the number of trainees going into academic surgery. What are other causes? Education, surgical education, you all know this, is very costly. There's increasing educational debt. Many of us are under pressure to generate income, and the easiest way to do that for our hospitals is by seeing patients. Many people see research careers as very challenging. Some say that if they do surgical science, they're not appreciated, valued, or respected by their clinical colleagues. And again, funding is going away, and reimbursement in general is going down for clinical practice. Well, let's turn back the clock and go back into the Roman days and think about the philosophers. And this is sort of an intellectual exercise, but I've read a lot of classical philosophy. I like the classics. And I would imagine that if there was a philosopher who was a clinical surgeon, it would be Aristotle. Why do I say that? Well, because Aristotle said, quote, we are what we repeatedly do. Excellence then is not an art, but a habit, meaning practice makes perfect. The more operations you do, the better you do them. So Aristotle would be a clinical surgeon. However, Socrates, I think, would be an academic surgeon. He said, quote, I know that I don't know. And another Socrates, quote, to know is to know that you know nothing. That is the meaning of true knowledge. So that's really where the academic surgeon comes from, is striving to explore the unknown and to be innovative and creative. Well, sadly, at least in the United States, the archetype of the surgeon scientist has been, and maybe even to some degree still is, the person on the right. That is a white man doing basic science in a laboratory. And this concept of the triple threat, someone who is a clinical surgeon, a researcher, and an educator, is the paragon of academic surgery. But sadly, this probably is an extinct series, a phenotype. There is no such person who does all things well. And this is another very famous academic surgeon. This is William Stewart Halsted, who spent much of his career at Johns Hopkins. So I think, and I will argue today, that these are old-fashioned, arcane, and irrelevant to today. I think the modern academic surgeon is a much more diverse phenotype. Yes, it could be a basic scientist, but it also could be a clinical researcher. It could be a health services researcher, an education researcher, a global health researcher. It could be a master teacher, master educator, a master clinician, or even, and you may recognize this from classical literature, the chimera. Someone who is a little bit of many different things. Some of you may know this from social media and Twitter. This was from a couple of years back, where different people look at the same picture and they see different things based on the way their retinas and their eyes are constructed. Some people look at this dress and see a gold dress, but others look at the same dress and see a blue dress. What's the point? You can see different things from your different perspectives. What I would argue is that creativity, discovery, and innovation are essential. Well, some of my colleagues say the mantra in surgery is practice makes perfect, meaning what a clinical surgeon says. The more you do it, the better you get. So is it possible to be creative and innovative and also an academic surgeon? I would say absolutely. You can be both things at the same time. But the important thing as an academic surgeon is to ask big questions, important questions, and answer them in novel ways, which ultimately have relevance to what we do each and every day in our clinics and in the operating room. And I think the important thing as you move through your lives is to keep an open mind and be willing to reassess what you think you know. And today I'm going to give you some examples of where I thought I knew the answers and where I was wrong. And only through innovation and discovery did we dismantle falsehoods to restore truth. So I'm going to talk a little bit about something I know for a few minutes, which is thyroid cancer. And I'm going to keep it pretty simple. And maybe you'll learn something about thyroid cancer to help you on your examinations. So this is a picture of the epidemiology of thyroid cancer in the United States. I used to say there's a pandemic of thyroid cancer, but I no longer say that thanks to COVID. I say there's an epidemic. And what's the takeaway here? There's an explosion of incidence of the disease. It's up by more than 300% over the last 3 decades, and it's affecting every different demographic subgroup. So tons of people have said, what the heck is going on with thyroid cancer? What is this explosion of incidence? So this is a very famous paper from JAMA, published in 2006. And let me walk you through it. So on the left, upper left-hand corner, you see the incidence of thyroid cancer rising. And what appears to be the engine is papillary thyroid cancer. So a single histologic subtype. On the right, you see the incidence of papillary thyroid cancer rising based on the size of the tumors. And it appears to be these tiny tumors, less than 1 centimeter in size, that are the genesis of things. And then finally, this very, very famous figure at the bottom, which shows incidence rising, mortality flat, leading the authors to say, quote, we believe increased diagnostic scrutiny is the most likely explanation for the apparent increase in incidence. That is, it's all overdiagnosis. Well, I gotta tell you, I always was bothered by that JAMA paper. I must have read that paper 30 times. And I kept coming back to this figure on the left with incidence rising. So very large numbers. The incidence of thyroid cancer in the United States is in excess of 50,000 new cases per year. And then I was struck by the fact that mortality was flat, but mortality is a very rare outcome, fortunately, in thyroid cancer. So what concerned me about this figure is that it's on an arithmetic scale. So you have a big number and a small number on the same scale. And therefore, I wondered, is it not possible that the way this graph is made could be muting actual changes in mortality because of its small numbers? So I'm not an epidemiologist or a biostatistician, but fortunately I have friends who are. So I called up my friend Carrie Kitahara, who's an epidemiologist, and I said, Carrie, take these data and take them off of the arithmetic scale and put them on a semi-log scale. Took her 30 minutes and she sent me this figure back, which subsequently was published in Nature. And what you see is that incidence is still rising, but now with the semi-log scale, you start to see increases in mortality, which had been disguised before. With that, we wrote a paper, and it too was published in the journal, prestigious journal JAMA. And all we did was ask the same questions as Welch and Davies, and we used the same data and changed just two things in a thoughtful way. So we used the same data sources as Welch and Davies for incidence and for mortality. But the first thing we changed was that instead of using mortality, we used incidence-based mortality, which is a superior outcome when you're dealing with a disease that has a rare outcome, which thyroid cancer does when it comes to mortality. And then we did similar analyses to Welch and Davies, but we changed the second thing, and that is simply how we presented the data. And instead of using arithmetic scales on our graphs, we used logarithmic scales. And let's see what we found. So here's papillary thyroid cancer incidence. You see that it is rising, but in contradistinction to Welch and Davies, it is not just these tiny tumors that are increasing in incidence, but it is also, look at this, tumors that are very large, over 4 centimeters in size, the size of golf balls. Nobody would say that these very large tumors are the result of overdiagnosis. These are tumors that, in fact, people can succumb to. And then when we looked at mortality, no longer do we see flat mortality. We see mortality that is rising, which is very rare. Why? Because today in 2021, we are winning the war against cancer, except for 4 cancer diagnoses. Number 1, hepatocellular carcinoma, and now we know number 2, thyroid cancer. And we see that even for the tiniest tumors, less than 2 centimeters in size, mortality is sharply rising at a rate of 6.8% per year. So while we agreed with Welch and Davies that overdiagnosis is at play, we believe that there are clearly other explanations for what is going on. What's the takeaway for you in the audience? You can ask old questions, but answer them in new ways and do profoundly impactful research. So evidence always should inform what we do in the way we provide cancer care or any surgical care. Well, let's switch gears. And now I'm going to start to highlight what you can do as a learner, as a trainee. So let's talk about surgery for low-risk thyroid cancer. So these are tumors 1 to 4 centimeters in size, confined to the thyroid without metastatic disease. So this, as many of you may know from medical school, is the age-old debate, should you take out the whole thyroid or half the thyroid? So those people who say take out your whole thyroid say often cancer, differentiated thyroid cancer, is multifocal and bilateral. We may want to use radioactive iodine afterwards. And if you take the whole thyroid out, it's easier to follow thyroglobulin levels. Well, those who say you don't need to take the whole thyroid out, take out half, say who wants thyroid hormone supplementation, let alone replacement? It's an indolent disease and people rarely die. There are more complications with bigger surgery. And in the end, please demonstrate to me a survival benefit. So for many, many, many years, guidelines recommended we take the whole thyroid out. Well, what was that based on? So it's amazing how precarious evidence is when you actually review it. And all of the evidence basically came from one study published in 2007 by Villamoria et al., looking at 52,000 patients with differentiated thyroid cancer. And let's just cut to the chase. Here's the very famous table from that paper, which shows comparing total thyroidectomy and lobectomy survival. You see that for those patients who underwent lobectomy, they had a 31% increase in the risk of death compared to patients who had total thyroidectomy. And this was deployed as the evidence to support doing total thyroidectomy. Well, I gotta tell you, when those data were published in 2007, my eyebrows went up and I said, that's crazy. That is not my experience. So here's a theme to what I do. I said, let's redo that Villamoria study, but enrich the data because I believed Dr. Villamoria's data was missing some incredibly important variables that could have impacted the findings. This study, which was published in the Annals of Surgery, was led by Dr. Mohammed Adam. Dr. Adam was born in the Sudan and came to the United States after medical school. I met him at Duke University. He is my mentee, and he published this paper when he was a third-year resident. It transformed the way we practice thyroid surgery internationally. So this is something you can do as a resident. So basically what we did was we repeated the Villamoria study, looking at a number of demographic, clinical, and pathologic variables to see whether lobectomy or total thyroidectomy was associated with superior survival. Here are our data, looking at nearly 62,000 cases, lobectomy on the left, total thyroidectomy on the right. You will see statistically significant differences based on these demographic variables. I would argue they are not clinically significantly different, but these are, and all of these variables were missing in the Villamoria study. And it's not because Dr. Villamoria is anything short of an amazing scientist. It's simply that he had limitations in his data set. We enriched the data set and then were able to adjust for these important independent variables. And when we did, what we found is that in the end, survival is equivalent for total thyroidectomy and thyroid lobectomy. So this is in contradiction to what Dr. Villamoria found, with a p-value now not significant at 0.40. So in 2009, the American Thyroid Association had recommended total thyroidectomy for low-risk differentiated thyroid cancers based on Dr. Villamoria's data. And in 2015, based on Dr. Adams' data, the recommendation is either total thyroidectomy or thyroid lobectomy. In the end, the decision needs to be made based on patient preference and their preference around risks and benefits of each strategy. So what would I conclude from this? Well, the whole truth is often hidden from view, just like icebergs are largely hidden from view under the surface of the water. Indeed, many environmentalists now say, are there even any icebergs left? And just as icebergs are melting, so too might be truth. Well, what should we do as surgeon scientists? We need to fight back to establish truth and separate it from fiction. I'm going to give you one more example of how we think we know what we know, and in fact, the underpinnings are really quite shaky. So again, one more example from thyroid cancer, because it's what I know about. So this is the way we stage differentiated thyroid cancer internationally. It's based on the AJCC UICC staging system. I'm going to show you the 7th edition. We are now on the 8th edition. The only change is 45 years has become 55 years. But here's the weird thing about staging for thyroid cancer. We treat young patients differently from how we treat older patients. And there is an age cutoff of 45, now 55 years. And what the difference is when you are young, less than 45 or 55 years of age, we do not count against you having metastases in your cervical lymph nodes. You are stage 1 unless you have distant metastatic disease outside of the neck, in which case you become stage 2. But if you are older, you can be stage 1, 2, 3, or 4. In fact, if you have metastatic lymph nodes in the neck, you immediately move to stage 4A. So for some crazy reason, in thyroid cancer, we think differently based on the age of the patient. And it is the only cancer for which there is this kind of staging system, which is crazy. And if you were to say to me, but Dr. Sosa, we use a different staging system in our country, every staging system I am aware of in the world builds in this consideration of age, but no other cancer staging system does. Does that make any sense? It's crazy. And I thought it was crazy. So guess what I did? I called Dr. Adam, who was my mentee as a third-year resident, and I said, Mohammed, we need to question this. It doesn't make sense. And so he and I and our colleagues at Duke at that time did this study published in the Journal of Clinical Oncology with an impact factor of 35. And we asked 2 simple questions. Does the presence of lymph node metastases in the neck, in fact, compromise survival of young patients? And if so, does the burden of disease or the volume of metastatic disease in the neck matter? So what did we do? We used a couple of large population level data sets that have a very large number of independent and dependent variables. Again, our purpose is to predict survival, because that is what cancer staging is intended to do. And we took young patients with differentiated thyroid cancer, and we did something very simple in this large data set. We divided them into those without cervical lymph node metastases and those with lymph node metastases in the neck. We then did a number of unadjusted and adjusted survival analyses, like Kaplan-Meier and Cox proportional hazards. But then we did something really cool. And that is we used something called restrictive cubic splines. Now, if you're not asleep already, please don't go to sleep, because this is super simple and it's super cool tool to have in your toolkit. So what are restrictive cubic splines? So you're driving really fast, too fast, and you hear a police siren behind you. So you slam on the brakes. What we know is that the faster you were going, the longer it takes to stop. So that is a linear association. And what we know is all regression analyses assume a linear association between independent and dependent variables. The problem is not all variables have a linear association. So I was born in Canada. I'm an international surgeon. And in Canada, in Montreal, these are temperatures based on the time of the year. And in Canada, all we think about is cold and colder. So what we see is that obviously the temperature in Canada varies based on the month of the year. But it is not a linear association. You cannot fit a line to the variation in temperature. So what do restrictive cubic splines do? Something very simple. They relax the assumption of linearity that is otherwise assumed in multivariable linear regression. Now listen, I'm a surgeon. I can do anything, but I cannot do everything. And so what that means is it is important to have smart friends and collaborators in your research community. I would argue big data, team science is the future. Surgeons should serve as the leaders of the team, given the leadership role we have in the operating room. So I enrolled biostatisticians to help me apply restrictive cubic splines. And look what we found. Here's the prediction of death on the y-axis and survival on the x-axis. And this is prediction of death. So what we see is that young patients with cervical lymph node metastasis indeed die sooner than similar young patients without lymph node metastasis. And this difference is statistically significant. This flies in complete contradiction to all staging systems for thyroid cancer. And we found the same thing in another national data set, statistically significant differences. And what we found is that each incremental lymph node up to the number 6 confers a survival disadvantage. And after 6, this is the restrictive cubic splines, you see a muted relationship between the two variables. So what did we conclude from Dr. Adams' study? It is that cervical lymph node metastases are associated with death in young patients. This is not what staging systems say. And so in current staging systems, we are understaging patients who are young and almost certainly undertreating them, which means we are doing a disservice to young people. Well, let's step back now and review the 3 examples I've given you. And a teaching point for everyone on this Zoom is that I think too many of us spend our lives building buildings horizontally, meaning we dabble in different areas trying to be an expert. But in the end, we're a jack of all trades and an expert in none. And what I would say to each of you is find your specific passion and build vertically. Build a body of evidence, perhaps in a narrow field, such that you, like Dr. Adam, can become an expert, a thought leader in that specific area. And the area in which I have worked is surgical health services research. In the United States, at least, this now represents a majority of the science that we do in surgery. And is it impactful? So these are articles written in our newspapers, the Washington Post, the very famous New York Times. These are articles written about the studies I just showed you, written by Dr. Adam. This is the kind of impact you can have when you do rigorous science. So now let's step back and make some general conclusions from the examples I gave you. So first of all, medicine, surgery, and science are team sports, like soccer, like football, like baseball, like basketball. Individual players have strengths and weaknesses. Games are played with rules and boundaries. We all have to agree on goals, and we all have to practice what we do to become better. The coach of the team is the mentor. It is the mentor that should ask the question. The question is the critical starting point, as Albert Einstein said, and the mentor with the most experience should ask the question as the coach of the team. Well, who is a good mentor? A mentor is someone you respect. It also has to be somebody that you like. It's somebody who should have good interpersonal skills and a track record of helping junior scientists become independent. It should be someone who has the time to spend with you or who is willing to make the time. And finally, it has to be someone that you trust. Well, who was Mentor? So this is International Women's History Month, so I couldn't leave this out. So in Greek mythology, you can tell I'm a student of the classics. Mentor was the son of Heracles. He was placed in charge of taking care of Telemachus. Telemachus was Odysseus or Ulysses' son. But here's the fact that many people forget. Athena, a woman, Athena, disguised herself as mentor and advised young Telemachus on many matters. So in the end, the first mentor, in fact, was a woman. Super cool. Who is a mentor today? Well, a mentor can be a man or a woman. It's someone who imparts wisdom to or shares knowledge with a less experienced colleague. It's that person who says to you, I've been there, I've done that, learn from my mistakes so that you do not have to make them. But everything a mentor does is not easy. Mentors have to give some, what we call in the United States, tough love. They have to provide constructive criticism. And they need to know their mentees well enough to see possibilities in mentees that even the mentee cannot yet seize. But remember, mentors are not a be-all, end-all panacea. In the end, each of you are who you are. Mentors can shape, help, and promote you, but ultimately, each of you is responsible for your own success or your own failure, by which I mean you've got to own it, okay? The mentor can help you, but the mentor is not a replacement for you being excellent. So what are the responsibilities of a mentee? Well, I think in choosing the right mentor, you have to understand what is needed and what is expected from the mentor. And I think it starts with introspection. Insight comes from introspection, meaning own up to what your strengths and weaknesses are and spend as much time as you can improving those weaknesses. You need to actively recruit a mentor. Assignments often don't work because people don't jive automatically. I recommend that mentees interview several potential mentors, maybe even experiment with several mentors to find that right fit. And as I said before, researching a mentor's track record is really important. So ask for their CV or have them over for a coffee and say, can you give me some names of prior mentees who I could speak to learn about their work and experience together with you? But remember, you as a mentee have responsibilities and you need to understand the responsibilities. So first of all, be respectful of the mentor's time and effort. Always bring enthusiasm and hard work to the relationship. Don't blow off and cancel meetings or show up late. It's disrespectful. Communicate, send emails, text, call, write letters even to your mentors. Be fair, be honest, and speak up. And frankly, if the relationship with your mentor feels artificial or fake, change it. And lastly, mentors don't get paid for mentoring. No one sends a check in the mail and says, gosh, Dr. Sosa, you're such a good mentor, here's a bonus. No, where we get the payback is the recognition and the appreciation that we get from our mentees. This morning, I've had an amazing morning because one of my mentees sent me an email that told me where she matched for residency and where she thanks me for the role I played. I'm on cloud 9 because she has been successful. So let's come back to Dr. Adam. So we left off the story where Dr. Adam was a third-year resident at Duke University in North Carolina. He then graduated from Duke and went to the University of Pittsburgh for a cancer surgery fellowship. But I never forgot Dr. Adam because he is so extraordinary. So when I heard from him that he was getting ready to graduate from fellowship, I called him and said, we need you at UCSF. And we recruited Dr. Adam, and he is now an assistant professor on our faculty in San Francisco, California. And within months of his arrival at UCSF, he already was being recognized with prestigious grants and awards. So pride in the mentee brings joy to the mentor. And the last message I would like to say to you is the power of serendipity, and that is chance. I never planned to meet Dr. Adam. I met him in a party and I never forgot him. So discovery is often not planned. Take a chance, accept risk, be dissatisfied with the status quo. Question as you see we have, question what you read, challenge it in new ways, always being a little uncomfortable. That's a good place to be, and it's a good way to feel as a scientist. And finally, we've talked a ton about career and professional development, but remember, life is bigger than work, and work-life integration, not balance, but integration is critical. I will tell you, I spend too many hours like this at home, asleep, exhausted by what I do. Do I love what I do? I absolutely adore being in the operating room and curing patients of thyroid cancer and following the careers of my residents and trainees. But life is also about the personal. You have to love where you live and who you live there with as much as what you do in the operating room. And I would be the first to say the personal always, repeats always, trumps the professional. Strong friendships are molded by similar passion. Academic surgery is an international and incredibly diverse community. Spend time meeting people like this from around the world. These are all pictures taken from different international meetings that I've gone to. It is when the personal and the professional mix that you will have the most joy from surgery. And in fact, this is our UCSF Department of Surgery on the bottom. You will see our faculty photo, and you will see so many people smiling. Why? Because we love what we do, and we love doing it together. And this is us in the top, and you can see the joy that comes from American surgery. So with that, I'd like to finish the talk on Twitter. This is my Twitter handle. This is the Twitter handle of the World Journal of Surgery. I would encourage you to follow it. It is an amazing place to submit your science. And in fact, we have a new initiative called My First Paper, where if you submit your first publication to the World Journal of Surgery, and if it is accepted, we celebrate you on Twitter with a picture, a visual abstract, and a summary of your study. And if any of you ever aspire to come to San Francisco, and I hope you do, this is the UCSF Surgery Twitter handle. So with that, I will finish my presentation, stop sharing, and I'd again like to thank the organizers of this Zoom for the privilege of presenting. Thanks so much.
Wow. Let me speak on behalf of our IASSS committee and our attendees in saying, Dr. Sosa, thank you so much for this phenomenal presentation. And what a wonderful way to begin our talk series with such an enlightening and inspiring session. We have a number of questions that were submitted in advance of the session, and I think you have covered several of them. In the interest of time, I'm going to focus on the ones that were most relevant to the discussion today, and hopefully for those who submitted questions, the rest will be covered in our future talks. So the first one I'd like to throw at you, Dr. Sosa, is whether or not, in your opinion, all trainees in a surgical discipline have an obligation or a responsibility to be involved in research.
Yeah, thank you for that question. And I never, God, did I just say never? I never say never and always. Well, there, I just broke the rule. You know, I don't think anyone has to do anything. I think when we ask people to do things for which they do not have passion, they will be unsuccessful and they won't enjoy it. So do I think you have to do anything in life? No. In fact, I encourage people to follow their passions even when they are the path less traveled. But I think to know that you don't enjoy something, see, that means you have to have had some exposure. So I guess what I would say in answer to your question is, I think everyone should have some exposure of some kind to science. If that exposure results in curiosity, pursue it, pursue it, pursue it, pursue it. But if that's not where your passion is, if passion is around teaching, or if passion is around that practice makes perfect and just dedicating yourself to clinical care, then that's fine. But don't make those kinds of decisions without first exposing yourself to the larger universe.
Thank you. So next, I'd like to acknowledge that we had a lot of questions in advance of the session about how to get involved in research in the first instance. And I think you've emphasized today that mentorship is key to that, and that mentors should be the ones asking the question. So I think the next question is the first step in getting involved in research to find and associate yourself with a mentor and then focus on being a good mentee?
Yeah, so I think that's right. I think it is very hard when you are junior to do high quality science because, as I said, the science starts with the question. And questions are often based on judgment, experience, knowledge of the field, and knowledge of where there are deficiencies in the field. And at the very least, that's what a mentor can offer, the team and the mentees. So yes, I think first find the mentor or mentorship team. A mentor shouldn't be one person. In a perfect world, you have multiple mentors. Some are local, near you, proximal. Some are distant. I call them remote learners. Now, you made the question of, so should you find a mentor and then sort of start mentoring? And I'll tell you, mentoring, when it's done well, is really, really, really hard. It takes a lot of time and commitment. And I've worked all of my life to try to be a good mentor. I get better and better every day, but I am still continuing to get better. And I would say to mentees, focus first on yourself, meaning making yourself the best you can be. before investing time and energy on your own mentees, you need to take care of yourself. And when does that transition occur? Well, in small ways, it can start when you're junior. But to become a really good mentor takes a ton of time. And I think you wouldn't want to spend time doing that until you're maybe mid-career, something like that. And it's okay to focus on self, to be a little selfish at the beginning of your career, because that's where you establish your reputation.
Great. So maybe a follow-up question to that is on the topic of building a body of research yourself, and to what extent do you think it matters whether a trainee or someone who's interested in pursuing a career as a surgeon scientist is involved in research that's in an area of their interest versus an unrelated field where maybe a mentor is more supportive?
Yeah, that's a really good question. And this is, I wish those synergize, but often they are in conflict. I'd make a couple of observations. When you are looking to get a job or get a position as a resident or a trainee in a prestigious program, say, the most important thing is that you learn the fund of knowledge and the skills to do superlative science. So early on, it is important to gather tools for your toolkit. And I would say it's more important that you do good research, good science, than you do it in your field. And the point I would make is you want to be an orthopedic surgeon. I think it is better to do superlative science in hypertension than bad science in orthopedics. However, once you have chosen your field, I think it is important to align your passion with the area of focus. If you're going this way in your clinical practice and that way in your science, you will waste energy. You want the two to come then into parallel such that you are efficient in the two portions of your professional life.
Okay, thank you. And so then I suppose following from that, on the topic of conducting so-called responsible research, what's the onus on surgeon scientists to keep that in mind, that when they're conducting research, it should be done in a responsible way so that you don't end up with multiple publications with large data sets ending up in very high impact journals that maybe are misleading or not truly reflective of the clinical situation? And what's the primary responsibility of the surgeon who is publishing that research in the first instance, not to allow that to happen?
Yeah, I wish I could tell you that everyone is ethical in international surgery. They are not. And in each year of the last 3 years that I have served as the editor-in-chief of World Journal of Surgery, sadly, I have had more than one example of surgeons who cut corners, who double published, who plagiarized. And so it exists. And I would say that there is no room in life for falsehoods and lies, particularly in medicine, in patient care. So when you're asked, what's the blood pressure of the patient? And you forgot to look, even though the patient looks fine, is eating breakfast, is talking on the phone, you say, I don't know, because I didn't check. So there's no room for it. I hold everyone in the team responsible when there are unethical behaviors. But if you want to know who I hold the most responsible, it is the senior author. And if the senior author says to me, I didn't know, I was only editing the manuscript, I didn't know what the other authors, I don't care. It's your job. It is the job of the mentor, the senior author, to know what is done, to know how it was done, and to assure that everything is done ethically. So if you're the mentee and you don't know which way to go, you go to your mentor. If what your mentor says doesn't sound right, you go to somebody else, a referee, an arbitrator, someone more senior, or someone in a different department who is not vulnerable to that senior person. All we have is truth and our reputations to do what is right always. And I would say that in the laboratory, and I would say that in patient care.
Mm-hmm. Yeah, I think that's a really important perspective to have from someone like you. So I think maybe, I know we're running over, but I'm just dying to continue this Q&A. I'll just ask one final question. It's a little tangential, but tonight we have attendees from, I think we had signups from 41 or 42 different countries. So just following from that, I just wanted to say, I know you told us collaboration is key. And so I guess moving forward, especially within the current global context, what do you feel is the role for international collaborative research to facilitate high quality research, not only in centers of excellence in UCSF or other places where, funding exists for research, but also in low resource settings where maybe research is a bit more of a luxury?
Yeah. So first of all, as the editor-in-chief of the World Journal of Surgery, I will say I believe strongly in international research, international collaboration, and science that is generated in lower and middle income countries. And I don't know if the folks on this call know that any manuscript about a lower or middle income country, so science about the developing world, lower middle income countries, must have at least one author from that country, because we believe strongly that you need collaboration and you need expertise locally. And I know many of my colleagues in prestigious journals don't do this. They let authors in Boston write about the Sudan when nobody is from the Sudan. This is not right. So the World Journal of Surgery is very unique in its belief in and support for global health, global surgery, and global science. I would say the pandemic has been devastating for so many in so many ways. But one silver lining is that it has made communication via digital methods like this so easy, right? So easy to talk to people anywhere in the world. And the example I gave you with Dr. Adam from the Sudan is the way I feel about collaboration. That some of the very best scientists are not in the United States or Europe or North America. They're in many different places. And communication through events like this are how we form those connections. And that's why, I'll be honest with you, anytime y'all call me, I will call you back and do the Zoom, because I believe in serendipity, okay? And the last example I would give you is I try to bring this into every part of my life. So right now in the United States, we're writing guidelines for how to manage patients with thyroid cancer. And it's put on by the American Thyroid Association. But I said, as the chair of the task force, if you want these to be international guidelines, this is nonsense. We need authors from all around the world contributing to these guidelines. And so I will tell you, for the first time, I think we have 15 or 14 people on our guidelines group. 4 are from outside of the United States. So this is the way I think we are going to behave in the post-pandemic reality.
Yeah. Amazing. So I think in the interest of time, we should leave it there. I just want to reiterate on behalf of the committee and everyone who has joined us today and everyone who will watch this, the recording once it's made available. Thank you so much for giving your time so generously and for really just amazing us about what is possible and how we can be involved. I will leave it to you to close.
Well, great. I'm sorry I can't see all of you and meet all of you in person, but please consider submitting to Reading the World Journal of Surgery. And at the next International Surgical Week, there'll be a virtual week later this year in August. But when we're back to meeting in person, find me, come talk to me, join our writers' workshops where you'll meet with me and my other co-editors who can help you to not only do the best science, but also communicate about it. So best wishes, good luck, and I can't wait to meet each and every one of you.
Thank you.
All right, ciao from San Francisco. Bye.
Thank you. Bye.